On my Q&A tonight, I'm going to be answering as many questions as I can. You've sent me loads of questions about hormones in younger women. So I've put them on my laptop and I'm just going to go through them as quickly as I can to try and answer as many. It's been wonderful that you've sent me so many questions. A lot of people are young and have perimenopause, menopause or hormonal changes causing symptoms related to PMS, premenstrual syndrome, or PMDD, premenstrual dysphoric disorder, or even postnatal depression, because all of these are hormonal changes that can occur. The youngest patient I've had was menopausal when she was 12. Her ovaries didn't develop properly, so then she didn't receive the hormones from her ovaries that she needed. So she was menopausal at school. It took 10 years for her to see someone to make the diagnosis, and another 8 years to receive the right treatment. So no one is too young, and obviously no one is too old, because once we are menopausal, we have low hormones forever. So it's really important that younger women aren't just dismissed, and too often I hear stories of women being told that they're too young, even if they're in their 40s, which doesn't make sense at all. But we know around 1 in 30 women under the age of 40 will have menopause at a younger age. So that means far more women will have perimenopause too. So there are lots of resources on our Free Balance app, also on the website, and I've done some podcasts as well with women who have had early menopause and actually talking to other healthcare professionals. So lots of free resources, but I'm going to just try and answer as many questions as possible. So I'm going to put my glasses on so I can read them. So first one is, can hormone therapy help with PMS, mood swings and brain fog before a period? Absolutely can. So before people find that their periods stop, often what happens is that people have symptoms just before their periods, and that's when our hormones generally are at their lowest, especially progesterone and estrogen as well. And when I say estrogen, I mean estradiol, which is the natural, beneficial type of estrogen. So sometimes people with PMS or PMDD, we just give hormones for those few days or a week or so when hormone levels start to dip, especially if people are feeling well the rest of the month. So we'll often give either or a combination, estradiol, progesterone, often do testosterone levels, and if they're low, consider that as well. So often it's really important to have natural hormones, not synthetic hormones, especially the natural progesterone, which we can give orally or as a pessary. How long after being on HRT should you have a checkup with the doctor? Usually about 3 months or so, because it can take a little while for hormones to have an effect. Can you use Vagifem indefinitely? So Vagifem is a estrogen. It's a pessary. It's a tablet, vaginal tablet, very, very low dose, and usually people can take it forever. Increasingly, I'm using something called prasterone. In the UK, it's called Intrarosa, which is DHEA, which converts to both testosterone and estrogen in the vagina as a daily pessary, which is a lot more effective. Hormonal migraines during perimenopause, how to treat them with HRT. So often hormones can be triggered by changing hormone levels. So when hormone levels fluctuate, which they do a lot in perimenopause, it can often trigger and worsen migraines. So actually having hormones as a stable amount can really make a difference. Usually with patients I give them patches just because it's more stable, and we might start with a very low dose and then gradually increase. Sometimes during the perimenopause though, people need higher doses to suppress this hormonal swing that can occur. So it's very, very individualised. There's some anecdotal evidence and also some clinical experience evidence that shows that women using testosterone can actually improve with migraines as well. Can a surgical menopause female be on testosterone for the rest of her life in good health? Yes, we don't have any data about testosterone in long term, but it makes sense. It's just a natural hormone. Testosterone is a biologically active hormone that works all through our body. So a lot of people find taking it forever is fine. We just review people every year, make sure their testosterone levels were within the normal female range. Very few of us want to stop taking it because we know the benefits it gives to us. Let me just go to the next ones. How can I deal with anxiety in perimenopause? So anxiety can be related to obviously lots of things, but hormone changes can trigger anxiety. Our hormones work with other neurotransmitters in the brain. When their hormone levels fluctuate or reduce, it can cause anxiety as well as low mood, irritability, anger and so forth. So often balancing the hormones can make a real difference. A lot of people find progesterone in particular is very calming on the mood, and testosterone can be as well. So having the right hormones, we spend a lot of time in our clinic enabling people to have the right dose and the right type and combination of hormones. And it can take sometimes a few appointments before they really get the right balance for them. Very important to discuss. And obviously in perimenopause, the hormone amount that's needed might change as well as their own hormones decline. How to manage newly diagnosed underactive thyroid and early menopause. So our thyroid hormones work very closely with our estradiol, progesterone, testosterone. So if someone is on thyroxine, we often measure thyroid hormones very closely, because it might be that the requirement for testosterone reduces as they become more established on their HRT and testosterone. I was diagnosed with fibromyalgia, age 35. Was this actually menopause? Now, fibromyalgia is something that I wouldn't actually diagnose unless I'd rebalanced hormones properly. I see a lot of women in our clinic who have been diagnosed with fibromyalgia, and it's when they have the right dose and type of, especially testosterone with estradiol and progesterone, their fibromyalgia symptoms really improve. We know that our hormones modulate our pain response as well. So if we have low hormones, we're going to feel more pain for the same stimuli. I'm not saying that all fibromyalgia is due to low hormones, but absolutely hormones should be rebalanced before making a diagnosis and being on lots of painkillers. When is the right time to see your GP about symptoms? If you're having symptoms that you think are related to hormones, then you should see a healthcare professional if you want to take hormones, because the longer you leave it, there's two things. Your symptoms might get worse, but also your health risks will increase, because we know these hormones are very calming, they're very anti-inflammatory, they reduce risk of future diseases. So there are two reasons for considering hormones. One is to improve symptoms. Of course, we all want to feel better, but the other is preventing disease and improving our future health as well. 100 microgram estradiol and anxiety is still the worst symptom. What else can I try? Difficult to give individualised advice, of course, but if you're just on estradiol, then often the balance with progesterone and testosterone can make a big difference. Even people that have had a surgical menopause or have a Mirena coil can still use progesterone, and because it's very anti-inflammatory, it works on our brain as well. Can progesterone be increased for sleep and anxiety? So it depends on the dose and the clinical situation. Sometimes people find using it as a pessary, it gets absorbed as the pure progesterone. It can be better for anxiety, but actually having it orally, it can actually improve sleep because it stimulates something called GABA in the brain. So, and I have some patients that take it orally and vaginally, off license of course, but it really depends on the individual. And obviously testosterone can reduce anxiety, as can estradiol as well. Can you still get symptoms at 55 if your period stopped at 36? Sadly, yes. I mean, the average, when you read papers, the average length of time of symptoms is 7 years, but it really varies. I've seen women who have symptoms 30, 40 years after their surgical menopause. So we shouldn't be expecting our symptoms to go after a certain length of time. We should be addressing the symptoms and trying to reduce and stop them by having the right treatment. Should I stop my treatment after having premature greying since starting HRT? I don't think that taking HRT will cause your hair to be grey, so it's an individual choice at all. Of course, breastfeeding and HRT, everyone says no. Why? I don't really know actually, because hormones in HRT are very low dose. All they do is top up what's missing. And when people are breastfeeding, even a low dose can make a massive difference to symptoms. Actually, people are allowed to take oral contraceptive if they're breastfeeding. Oral contraceptive is synthetic. It's a lot higher dose than HRT. So if people can take contraceptive and breastfeed, I'm really not sure why anyone's saying no about taking HRT. So I would go to speak to someone who understands hormones maybe a bit better. Is testosterone ever prescribed for perimenopause? Yes, it is. Perimenopause is the time when symptoms start and people are still having periods, but hormone levels are dropping. I see a lot of women actually who have regular periods, but they have low testosterone. And so sometimes symptoms related to testosterone deficiency include low mood, reduced energy, poor concentration, poor sleep, muscle and joint pains, and brain fog, for example, as well as reduced libido. So it might be that you need testosterone earlier than you think. So it's definitely worth speaking to someone. How do I know when is the right time to go on HRT? That's a very individualised choice. We know the earlier people take it, obviously, like I say, the better their symptom control and their future health as well. So that you don't have to wait. And like I say, you don't have to wait till you're officially menopausal either. I'm 45, I've just been given vaginal estrogen for recurrent UTIs. Do I have to take it forever now? Often people do take it forever. It's incredibly safe, very low dose. But like I say, if vaginal estrogen doesn't work enough, then I would consider the prasterone, which is the intrarosa, it's called in the UK, which converts to estrogen and testosterone in the vagina, so that helps with the urinary tract as well, and can be really, really good for people with recurrent urinary tract infections. Hi Louise, I'm 44, hysterectomy with ovaries removed, keep getting UTI. Is topical estrogen my best option? Yes, but systemic hormones can still be considered as well. So about 20% of women who take HRT still need to take vaginal hormones. So if you're getting recurrent UTIs and you're on systemic hormones, then think about vaginal hormones as well. Why do some women go through perimenopause earlier than others? We're all different, aren't we? And we know that for some women, they have perimenopause and menopause at an earlier age. We don't know why. Sometimes it might be slightly genetic. If you've got family members who have had menopause at a younger age, then it might be that you'll become menopausal at an earlier age. But sometimes it's just chance. We don't know why everyone has an earlier perimenopause or menopause. Obviously, if you have your ovaries removed or they're damaged by certain drugs, for example, some types of chemotherapy or radiotherapy can affect the way ovaries work. So those people, of course, will have an earlier menopause. But we don't know. But the important thing is that it's recognised and treated appropriately. Are mental health symptoms more severe in younger ladies with menopause? It really varies. Often mental health symptoms are triggered because some people's brain are more sensitive to the fluctuating, reducing hormone levels. Now our brains produce estrogen, progesterone, testosterone. So it's not just what our ovaries are doing, it's what our brain's doing as well. And there are some women who produce less hormones than others in their brains. I'm 41, overnight my head went, awful feelings of woodiness like I'm on a boat, headaches. They can be related to menopause, also like tinnitus, lightheadedness, dizziness on standing, can be related to changing hormone levels, but we need to think about testosterone. All these hormones help build our nerves, like our structural nerves and the nerve signals as well. So it's really important to consider hormones. Obviously, there are other reasons why this lady might be having symptoms. Dry eyes, mine are so bad in perimenopause. Optician says my sight is fine, but I struggle. So dry eyes are very common. So is dry mouth, burning mouth. Again, even smell changes can occur. So all our mucous membranes can be affected when we have low hormone levels. And a lot of people find that having hormones can really improve. Especially testosterone can affect the meibomian gland and also tear production. Now you might be caught out when the weather's cold, as it is getting cold in the UK here. A lot of people have watery eyes even though they've got dry eyes. So when they go out into the cold, their eyes are just streaming, but actually they're told that they have dry eyes. It's a reactive thing. So again, important to think about hormones. Recent adenomyosis diagnosis, had to come off my HRT. Well, people can still have HRT if they have adenomyosis or endometriosis. It's the balance of hormones, so especially thinking about progesterone and testosterone and less about estrogen mainly. My mother is 65, she's had a coronary bypass, dementia in the family, had her last period at 39. Is it too late for her to start HRT? So no one is too old to take natural hormones. We've got the natural hormones, which are exactly the same structure as the hormones that we produce ourselves. So even low doses can be beneficial for the brain, heart, and the excuse me, and the bones as well. Sometimes with older people, it's still worth considering hormones, because even a small improvement might make quite a big difference. And so because the hormones we can give, especially like the gel of estradiol, we can give in a very low dose with a natural progesterone, maybe considering testosterone as well. So we see a lot of people in the clinic who are older, who've had many years without hormones, and we start a low dose and gradually increase. And a lot of people find they really improve. Estrogen gel on the arm is okay, but patch isn't. Why? That's just the way it's licensed. When they license medication, they're quite strict about where to apply it. So when they did the experiments, they did them using the gel on the arms and the legs and the patches below the waist. It doesn't actually really matter, because you're just using the skin as a vehicle. So it shouldn't really make any difference. And we know actually absorption of patches can really vary depending on location where you put it. But there isn't any biological or physiological reason why you can't put the patches above your waist, for example, or you have to apply the gel on your arms and you couldn't put it on your shoulder, for example. It's literally just the way that the manufacturers have stated it for the license. Does HRT dose lead to severe irritable bowel symptoms? Well, we see a lot of people with irritable bowel syndrome and heartburn as well, actually, and those symptoms can really improve with hormones, including testosterone, because for two reasons. We've got we've got receptors for those hormones all through our gastrointestinal system, but also when we have low hormones, our gut microbes really alter. So having those hormones back can improve our gut microbes, which then will improve irritable bowel type symptoms. So it's really important. There was another paper a couple of weeks ago in the British Medical Journal to say antidepressants can be very useful for irritable bowel symptoms. Actually, we should be thinking about the underlying cause. And if so, people have gastrointestinal symptoms that have started since being perimenopausal or menopausal. Obviously, we should be thinking about other reasons, but if it's likely to be related to hormones, doesn't it make sense to give the hormones back? Can you talk about skin problems as perimenopause starts? So I've recorded a few podcasts now with Dr. Sad Rajpal, who's a brilliant, so experienced dermatologist that I know very well. And we talk a lot about skin and hair changes. The skin is the largest organ in our body. We have cells that respond to estradiol, progesterone, testosterone throughout our skin. These hormones are very important for the way our skin functions, but also the blood supply, which feeds the skin its nutrients, but also collagen as well, and bone. So a lot of people find that their collagen reduces as their hormones reduce. So replacing those hormones can improve collagen as well as the skin texture. A lot of people find their skin becomes very dry, very itchy, and that is related to low hormones. Can you talk about vaginal dryness, how to improve the symptoms? So symptoms of vaginal dryness, soreness, irritation, discomfort can be very, very common during both perimenopause and menopause and beyond. And that's because those three hormones have receptors throughout the vagina, the vulva, around the clitoris, the urinary tract, pelvic floor as well. So quite a few people have symptoms related to urinary tract infections as well. So it's important to think about how we get those hormones back, because having those hormones back will increase the blood supply to that area, they'll improve the healing, they'll increase the thickness of the mucosa, reduce any discomfort and pain as well. So having pessaries, like I've said before, usually I give the prasterone first line because it's treating the underlying cause so much better, because it transforms and changes to both estradiol and testosterone. We've got a lot of testosterone receptors all around that area, so sometimes people find having localized estrogen isn't enough, so we can give systemic HRT, including systemic testosterone, with localized hormones, and that can make a massive difference to the vaginal dryness, soreness, irritation. But it's having the right dose and combination of hormones. And there are obviously non-hormonal moisturisers and lubricants that can be used. Just have to be really careful that they don't irritate as well. Next ones. How do you know when menopause starts? If on HRT for perimenopause? Of course, menopause is just a day. If you look officially, it's just a day when it's a year past your periods. And then after that time, we often still talk about menopause, but I suppose officially it's post-menopause. But it just is a time when we have low hormones. The only way would be to stop your HRT, wait a year to see if you have a period. But then you'll be a bit hacked off if you have a period after 11.5 months. Like, it doesn't matter, actually. A lot of us know when we become menopausal, despite taking HRT, because a lot of us still have some cyclical symptoms, and that improves with time. Obviously, when women are in their mid to late 50s, they probably will be menopausal. But it doesn't actually matter the label. The important thing is perimenopause and menopause are related to a hormonal deficiency. So thinking about hormones is really important. Can vasomotor symptoms occur at any time throughout the perimenopause phase? So vasomotor symptoms, flushes and sweats, of course they can occur. They're not the most common symptom, actually. The most common symptom are symptoms affecting our brain, such as brain fog, low mood, anxiety, so reduced concentration and so forth. But actually, flushes and sweats can occur anytime to anybody, and they really vary depending on how they affect people. Suggestions on how to respond when people say I'm too young. I think it's about educating people and saying no one is too young to be menopausal or perimenopausal. Everyone is different, and we know that many women are young with an early menopause and they're not being diagnosed properly. We know from some studies it can take many years for the diagnosis to be made, and many years more for people to have the right hormones, and that's often due to lack of education. I wasn't taught anything about premature ovarian insufficiency, POI, or perimenopause, or testosterone deficiency at an earlier age. But once we know it, we've got to share it, because there's too much suffering. And I worry about the health risks of untreated menopause in younger women. So it's about educating people is really important. A lot of information on our Free Balance app, of course. Why is society and healthcare professionals so lacking in knowledge of perimenopause symptoms? I don't know, but I wish they would improve, and people are starting to improve with their education. Weight gain and HRT. So a lot of people put on weight when they're perimenopausal or menopausal because their body's trying to get estrogen. If the ovaries isn't making enough hormones, then our fat cells can make a very weak type of estrogen called estrone. It's not the best type of estrogen, it's quite inflammatory, but it's made in fat cells, usually in the midline. Often when people take the right dose and type of hormones, actually, then their weight often reduces. A lot of people find taking HRT with testosterone, they get some conversion of fat to muscle, they can exercise more, they can build muscle better, they often lose weight as well. So HRT, the natural HRT, it's not usually associated with weight gain. How do I know if my joint pain is perimenopause or something else? Now, our hormones are very anti-inflammatory in our muscles and joints. A lot of us get symptoms of related to arthritis, muscle pains, joint pains and so forth. The only way of knowing is having the hormones back at the right dose, the right level, waiting for 3 to 6 months and seeing if your symptoms improve. We find a lot of women, their muscle and joint pains really improve, especially with testosterone added into HRT. So I would always think about hormones before making another diagnosis. Do you need to lower your cholesterol levels before starting HRT? It depends on the scenario. If your risk of heart disease is low, then usually I say take HRT first, and then usually the cholesterol reduces. So the LDL cholesterol, the so-called bad cholesterol, reduces, and then HDL, the good cholesterol, often increases with the right dose and type of hormones. How to identify if demotivation and interest in work and sport is hormonal and not situation. Isn't that really hard? Because so many of us feel that we have like reduced energy, low mood, because of our jobs, because of relationships, whatever else is going on, maybe stress at home. But often women know, like we're quite intuitive. And I think if you're questioning, could it be related to your hormones? It probably is. So don't undermine yourself. Don't think, oh, it's related to difficult times. Lots of people have difficult times but cope very well. But if you find that you're coping in a different way, or not coping rather, in a different way, then think about your hormones. That's another one. A lot of them are similar, that's why I'm hesitating. How would I know when I've hit official menopause, as won't the HRT keep me having a bleed? I've answered that already. DEXA bone scan, early menopause. Absolutely. So women who are young, have an early menopause, the guidelines are clear. We should all be offering these people a DEXA scan, a bone density scan. We've got one in our clinic, and absolutely everybody should be considering a bone density scan. So bone density scans are usually done every 3 to 5 years. We know the risk of osteoporosis increases when people have menopause at an earlier age. So thinking about DEXA scan is really important. How does infertility treatment affect your own hormones, and does it mean earlier menopause? Not usually. There isn't any evidence that the treatment for reduced fertility increases infertility. Sorry, I'll say that again. There isn't any evidence that giving treatment for infertility or reduced fertility affects menopause age, but a lot of women who have fertility treatments will have reduced ovarian reserve, so they're less likely to have good amounts of hormones in their body. And so a lot of people are having symptoms but being told it's due to the stress of not being able to conceive rather than related to their low hormones. We know that you can safely have natural hormones, including testosterone, when you're trying to conceive, including receive fertility treatments. Doctor says, lose weight before taking HRT. Is she just brushing me off? Probably. I think it's very hard to lose weight when you're not taking HRT and you're having symptoms. As I said before, menopause is a metabolic problem. So metabolism changes when we don't have hormones. And so actually a lot of people find it really difficult to lose weight. And we know that our hormones can interact with our insulin and glucose as well. So if we've got low estradiol, we're more likely to find it harder to control our glucose levels, definitely harder to lose weight as well. So I would go and see someone else. Why taking 2 progesterone make my body so stressed the next day? So some people vary with their response to progesterone. It's worth talking to your doctor, because sometimes rather than taking it orally, we take it, use it vaginally instead. Then last question, why do younger women tend to need higher doses? What's the reasoning or science behind it? Well, what we try to do when we give people hormones is give them back hormones in a physiological response. So we try and give them the right dose for them. We use levels as a guide. So often in our clinic, we do estradiol levels when people are on treatment. And we try to keep them between 250 and 1,000. But some people who are younger feel better when their level's more like 600 or 700 as opposed to 300. It really varies, and that's probably because that's the amount that they need if they were producing hormones adequately themselves. We also know that some people absorb differently. So some people, you give them the same standard dose and they absorb less just because their skin type is different to others. We know absorption really varies depending on the skin thickness, the skin temperature, the vasculature of the skin, whether there's any subcutaneous fat, for example. So some people need higher doses just because of their skin type rather than their age. And some younger people we know do often need a higher dose. We're all different, so many of us need different doses to other people, and that's really important. And that's why I've said at the beginning, you know, we spend a lot of time in our clinic really optimizing hormones for symptom control, but for future health as well. So looking at all 3 hormones in balance, We don't usually do progesterone levels because they're not a good guide of absorption, but estradiol is quite a good guide, and testosterone is as well. So the important thing out of all of this tonight is download Balance, look at a lot of our free resources, listen to various podcasts, read as much, watch as much, be empowered with information. And then the last step is seeing someone who really understands what's going on, so you can be treated as an individual, because it's crucially important, especially when you're younger, because it's likely that your menopause is going to be with you longer than before you were menopausal. So make sure that you have the right treatment choices and the right investigations that are right for you. And it might be that you need to see different people before that happens. So I hope that's been helpful. I know I've rattled through a lot of questions, but I thought it was useful just to go through as many questions as possible. So I will post some information for my stories in a bit, some resources for you, and I'll put this on my grid. So thanks for joining, and enjoy the rest of your evening and have a wonderful week ahead. Thank you.